On November 3, 2023, I assisted in what should have been a routine surgical procedure that turned into the most inexplicable experience of my nursing career. What started as a standard emergency surgery became something that challenged everything I understood about consciousness, medical intervention, and the nature of what makes us human. My name is Amanda Fletcher. I was a surgical nurse at St. Thomas West Hospital in Nashville, Tennessee, for 14 years until I submitted my resignation last month. In over a decade of operating room experience, I thought I'd seen every type of surgery, every possible complication, and every variation of how patients respond to anesthesia and surgical intervention. St. Thomas West Hospital is a Level 2 trauma center serving Western Nashville and surrounding communities. Our surgical department performs over 8,000 procedures annually, ranging from routine operations to complex emergency trauma cases. As a senior OR nurse, I was responsible for preparing surgical equipment, assisting surgeons during procedures, and monitoring patients throughout their operations. The case that ended my career involved a 29-year-old construction worker named Tyler Bennett, who had been brought to our emergency department after a workplace accident. Tyler had been working on a high-rise construction project downtown when a piece of machinery malfunctioned, causing a steel cable to snap and strike him across the abdomen with tremendous force. The paramedics reported that Tyler had been conscious and alert at the scene, but by the time he arrived at St. Thomas West, he had lost significant amounts of blood and was showing signs of severe internal injuries. The trauma team immediately took him to OR4 for emergency exploratory surgery to identify and repair the internal damage. Dr. Catherine Walsh, our chief trauma surgeon, was scheduled to perform the operation. I had worked with Dr. Walsh on hundreds of cases over the years, and she was known for her skill in handling the most complex trauma situations. The surgical team also included Dr. Jennifer Adams, our anesthesiologist, Dr. Kevin Foster, a surgical resident, and Jennifer Hayes, a newer OR nurse who had been with the hospital for about 2 years. That Friday afternoon in November started like any other shift. I had arrived at work at 7 a.m. and spent the morning preparing for scheduled surgeries and handling routine cases. Tyler's emergency surgery was called in at 2:15 p.m., giving us just enough time to prepare OR4 and assemble the necessary equipment for major abdominal trauma repair. Tyler arrived in OR4 at 2:45 p.m., conscious but in obvious pain. Despite his injuries, he was alert and able to communicate clearly with the surgical team. This was encouraging, as patients with severe internal trauma often lose consciousness due to blood loss and shock. "How are you feeling, Tyler?" I asked as we transferred him to the operating table. "I've been better," he replied with a weak smile. "But I'm ready to get this fixed so I can get back to work." Tyler's vital signs were concerning but stable. His blood pressure was low but not critically so, and his heart rate was elevated as expected with blood loss. Dr. Adams began the anesthesia process while Dr. Walsh and I prepared the surgical site. "Amanda, let's get 2 units of O-negative ready for transfusion," Dr. Walsh instructed. "We're going to need to move quickly once we see what we're dealing with inside." As Dr. Adams administered the anesthetic agents, Tyler remained conscious longer than typical. Most patients lose consciousness within 30 to 60 seconds of receiving anesthesia, but Tyler continued to talk coherently for nearly 3 minutes. "Dr. Adams, is there a problem with the anesthesia?" Dr. Walsh asked. "No, everything's normal. Some patients just metabolize the medications differently. He should be under in another minute or 2. But Tyler continued to remain conscious and alert, even as Dr. Adams increased the anesthetic dosage to levels that should have rendered him completely unconscious. "This is unusual," Dr. Adams admitted after 5 minutes of attempting to achieve adequate anesthesia. "He's received more than enough medication to be unconscious, but he's still responsive." Tyler not only remained conscious despite receiving massive doses of anesthetic agents, but he appeared to become more alert and coherent as the medications were increased. "Dr. Walsh, I can feel everything you're doing," Tyler said calmly as Dr. Walsh began preparing to make the initial incision. "But it doesn't hurt. It's like I'm watching from outside my body." This was medically impossible. The amount of anesthesia Tyler had received should have rendered him completely unconscious. unable to speak or respond to stimulation. Instead, he was carrying on a normal conversation while supposedly under deep surgical anesthesia. "Tyler, you shouldn't be able to talk right now," Dr. Adams said, clearly puzzled by his continued consciousness. "Let me try a different approach." She administered additional medications through Tyler's IV line, including powerful sedatives that should have knocked him unconscious within seconds. Tyler's vital signs remained stable, but he continued to be fully alert and responsive. "I know this is strange, Dr. Adams, but I can see all the monitors and equipment from up here," Tyler said, looking directly at the anesthesiologist. "My blood pressure is 95/60, my heart rate is 118, and my oxygen saturation is 97%. I checked the monitors he was referencing. His readings were exactly correct, down to the decimal point. "Tyler, how can you see the monitors from where you're lying?" I asked. The monitors were positioned behind his head and to the side, completely out of his line of sight. "I'm not looking from my body, Miss Fletcher. I'm looking from up there," he said, gesturing vaguely toward the ceiling. "I can see all of you working, and I can see myself lying on the table." Dr. Walsh faced an unprecedented situation. Tyler was clearly conscious and aware, but his vital signs indicated that he was adequately anesthetized from a physiological standpoint. His blood pressure and heart rate were consistent with surgical anesthesia levels, but his consciousness remained completely intact. "Tyler, I need to ask you something important," Dr. Walsh said. "You're telling us you can't feel pain, even though you're conscious." "That's right, Dr. Walsh. I can see everything that's happening, but I don't feel any discomfort. It's like I'm floating above my body, watching you work. And you're comfortable with us proceeding with the surgery while you're in this state?" "Yes, please continue. I can see the internal bleeding, and I know you need to fix it quickly." This response was deeply troubling. Tyler claimed to be able to see internal injuries that wouldn't be visible until Dr. Walsh made the surgical incisions and explored his abdominal cavity. Dr. Walsh looked at me and then at Dr. Adams. "I've never encountered anything like this, but we need to proceed. His injuries are life-threatening, and we can't wait for normal anesthesia protocols." "Are you sure about this, Catherine?" Dr. Adams asked. "Operating on a conscious patient violates every principle of surgical anesthesia. Look at his monitors, Jennifer. Physiologically, he's under adequate anesthesia. If he's not experiencing pain and he's consenting to the procedure, we need to save his life." Dr. Walsh made the initial incision across Tyler's abdomen at 3:20 p.m. Throughout the procedure, Tyler continued to provide commentary on what he observed, describing surgical steps and anatomical findings with remarkable accuracy. As Dr. Walsh opened Tyler's abdominal cavity, she discovered extensive internal injuries that were consistent with the mechanism of trauma he had experienced. There was significant bleeding from his spleen, liver lacerations, and damage to several sections of his small intestine. But Tyler's descriptions of his injuries had been completely accurate before Dr. Walsh had even made the first incision. "Dr. Walsh, you'll find the worst bleeding is from the lower pole of my spleen," Tyler said calmly as the surgeon examined his injuries. "There's also a grade 2 liver laceration about 3 centimeters from the falciform ligament and 2 perforations in my jejunum approximately 20 centimeters apart." Dr. Walsh stopped her examination and stared at Tyler. His descriptions of his injuries were not only accurate but used precise medical terminology that most patients wouldn't know. "Tyler, how do you know these medical terms?" I asked. "I don't know, Miss Fletcher. I can just see the injuries clearly from where I am, and somehow I understand what I'm looking at." Dr. Foster, our surgical resident, checked Tyler's chart. According to his intake information, Tyler has a high school education and works in construction. No medical background or training listed. But Tyler continued to demonstrate knowledge that seemed impossible for someone without extensive medical training. As Dr. Walsh worked to repair his spleen, Tyler offered suggestions about surgical technique and anatomical considerations. "Dr. Walsh, if you approach the splenic hilum from a slightly more lateral angle, you'll have better access to the bleeding vessels while avoiding the pancreatic tail," Tyler suggested. Dr. Walsh paused her work and looked at me with an expression of complete bewilderment. Tyler's suggestion was not only medically sound, but demonstrated understanding of complex surgical anatomy that would typically require years of medical education. As the surgery progressed, Tyler's impossible knowledge became even more apparent. He correctly predicted every anatomical finding before Dr. Walsh encountered it, provided accurate assessments of tissue viability, and even suggested modifications to surgical techniques that proved to be helpful. "Tyler, I need to ask you something," Dr. Walsh said as she worked to repair his intestinal perforations. "Have you ever observed surgical procedures before?"
Never, Dr. Walsh. I've never even been in a hospital before today, except when my daughter was born 3 years ago.
Then how do you know so much about surgical anatomy and technique? I honestly don't know. It's like the information is just available to me while I'm in this state. I can see not just what you're doing, but why you're doing it, and how it affects the tissues. Tyler went on to demonstrate knowledge that extended beyond basic anatomy. He understood the pharmacology of medications Dr. Adams was administering, predicted how his tissues would respond to different surgical techniques, and even provided insights into optimal suture selection for different types of tissue repair. "Miss Fletcher, Dr. Walsh should use 3-0 Vicryl for the bowel anastomosis, but 2-0 Silk would be better for the splenic capsule repair because of the tissue friability," Tyler said, as I prepared sutures for the next phase of the procedure. I looked at Dr. Walsh, who nodded in agreement with Tyler's recommendations. His suggestions were not only correct, but reflected sophisticated understanding of tissue handling and surgical principles. Perhaps most disturbing was Tyler's apparent ability to communicate information that he shouldn't have been able to access. As the surgery progressed, he began providing details about other patients and hospital operations that were completely outside his knowledge base. "Dr. Walsh, the patient in OR2 is having complications with her gallbladder surgery," Tyler said during a quiet moment in his procedure. "Dr. Martinez is going to need to convert to an open procedure because of adhesions." I checked with the charge nurse through our communication system. The patient in OR2 was indeed experiencing complications, and Dr. Martinez was preparing to convert her laparoscopic gallbladder surgery to an open procedure due to extensive adhesions. "Tyler, how do you know what's happening in other operating rooms?" Dr. Adams asked. "I can see the whole surgical suite from where I am. It's like I have access to information about everything that's happening in the hospital." Tyler went on to provide accurate information about patients in recovery, scheduling changes for upcoming surgeries, and even details about hospital administrative decisions that were being made during his procedure. "The blood bank is running low on AB-positive blood, and they're calling in additional donors," Tyler reported. "Also, the MRI machine in radiology is down for maintenance, so they're rescheduling afternoon scans." I verified each of Tyler's reports through our hospital communication systems. Every piece of information he provided was completely accurate, describing situations he couldn't possibly have known about from his position on the operating table. Throughout the surgery, Tyler's vital signs remained stable and consistent with adequate surgical anesthesia, despite his continued consciousness and remarkable awareness. Dr. Adams monitored his anesthesia depth using multiple parameters, all of which indicated that he should have been completely unconscious. "This is medically impossible," Dr. Adams confided to me during the procedure. "His brain activity monitors show patterns consistent with deep anesthesia, but he's clearly conscious and alert." "Could the monitoring equipment be malfunctioning?" I asked. "I've checked everything multiple times. All our equipment is functioning normally. Tyler's physiological responses are exactly what we'd expect from a patient under adequate anesthesia, but his consciousness is completely intact." Tyler seemed to be aware of our conversation. "Dr. Adams, I know this is confusing for you. I can see my own brain activity on your monitors, and I understand why this doesn't make sense." "What do you mean you can see your own brain activity?" Dr. Adams asked. "I can see the EEG patterns on your anesthesia monitor. They show delta waves consistent with deep anesthesia, but my consciousness isn't located in my brain right now. That's why the readings don't correlate with my awareness." This was perhaps the most disturbing aspect of Tyler's condition. He was describing his consciousness as being separated from his physical brain, existing in some location that allowed him to observe the surgical procedure and hospital operations from an external perspective. Dr. Walsh successfully repaired all of Tyler's internal injuries over the course of a 3-hour procedure. His spleen was salvaged, liver lacerations were repaired, and intestinal perforations were closed with primary anastomoses. Throughout the surgery, Tyler's suggestions and observations had been uniformly accurate and helpful. But as Dr. Walsh prepared to close Tyler's abdominal incision, something happened that was even more disturbing than his impossible consciousness during the procedure. Tyler's awareness suddenly changed. "Dr. Walsh, I'm starting to come back into my body," Tyler announced. "I can feel myself settling back into my physical form." "What do you mean, Tyler?" "My consciousness was floating above and around the operating room, but now it's moving back into my body. I can feel sensation returning to my arms and legs." As Tyler described this process, his vital signs began to change. His heart rate increased, his blood pressure rose, and his responses to stimulation became more typical of a patient emerging from anesthesia. "Dr. Adams, are you reducing his anesthesia?" Dr. Walsh asked. "No, I haven't changed anything. But his responses are changing as if the anesthesia is wearing off naturally." Within 10 minutes, Tyler had transitioned from his state of impossible consciousness to what appeared to be normal emergence from anesthesia. He became drowsy, his speech became slurred, and he lost the remarkable awareness and knowledge he had demonstrated throughout the surgery. "Tyler, can you still see the operating room from above?" I asked as Dr. Walsh closed his incision. "No, Miss Fletcher. I'm back in my body now. I feel tired and sore, like I just had surgery." Tyler's transformation was complete. The patient who had demonstrated impossible consciousness and remarkable medical knowledge throughout his surgery had returned to being a construction worker with a high school education recovering from trauma surgery. Tyler was transferred to the surgical ICU at 6:45 p.m. for post-operative monitoring and recovery. His vital signs were stable, and all indicators suggested that his surgery had been successful. But I was deeply troubled by what we had witnessed during his procedure. I visited Tyler in the ICU the following morning to check on his recovery. He was awake and alert, but showed no signs of the remarkable awareness he had demonstrated during surgery. "Tyler, do you remember anything about your surgery yesterday?" I asked. "Not really, Miss Fletcher. I remember talking to everyone before I went under, and then the next thing I knew, I was waking up here in the ICU." "Do you remember being conscious during the surgery?" Tyler looked puzzled. "I was conscious during surgery? That doesn't sound right. I thought I was supposed to be asleep for the whole thing." I described some of the things he had said and done during his procedure. Tyler listened with growing amazement, but showed no recognition of the experiences I was describing. "Miss Fletcher, I don't remember any of that. I don't know anything about medical terminology or surgical techniques. I build buildings for a living." To test his knowledge, I asked Tyler some basic questions about anatomy and surgical procedures. His responses confirmed that he had no medical knowledge or training. He couldn't identify basic anatomical structures, didn't understand medical terminology, and showed no awareness of surgical principles. Yet during his surgery, Tyler had demonstrated expertise that would have impressed medical school professors. Over the following days, I became obsessed with understanding what had happened during Tyler's surgery. I reviewed our electronic medical records, studied the anesthesia documentation, and researched medical literature for similar cases. I found a few scattered reports of patients who had maintained some level of consciousness during surgery despite adequate anesthesia, but none that described the kind of comprehensive awareness and impossible knowledge that Tyler had demonstrated. I also consulted with Dr. Adams about the anesthesia aspects of Tyler's case. She had documented everything carefully, but couldn't provide any medical explanation for what we had witnessed. "Amanda, I've been an anesthesiologist for 12 years, and I've never seen anything like Tyler's case," Dr. Adams told me. "By every measure we have, he was adequately anesthetized throughout his surgery, but he was clearly conscious and aware in ways that challenge our understanding of how anesthesia works." Could there be some medical explanation we're missing? I've consulted with colleagues at other hospitals, and no one has encountered anything similar. Tyler's case appears to be completely unique in medical literature. Dr. Walsh was equally baffled by Tyler's surgical behavior. Amanda, Tyler provided surgical insights that would typically require years of medical education and experience. Yet he has no medical background and no memory of his remarkable knowledge. Tyler returned for his post-operative follow-up appointments as scheduled. His recovery was excellent, with no complications from his surgery and complete healing of his internal injuries. But he continued to show no awareness of his extraordinary behavior during the procedure. During his 2-week follow-up visit, I decided to test whether Tyler's remarkable consciousness could be triggered again under controlled circumstances. "Tyler, I want to try something," I said during his appointment. "I'm going to show you some anatomical diagrams and see if you recognize anything from your surgery." I showed Tyler detailed illustrations of abdominal anatomy, including diagrams of the spleen, liver, and intestinal structures that had been repaired during his procedure. Tyler studied the images carefully, but showed no recognition or understanding. "Miss Fletcher, these are just pictures of body parts to me. I can't tell you what they are or what they do." I then showed Tyler video recordings of surgical procedures similar to the one he had undergone. Again, Tyler showed no understanding of what he was seeing and no recognition of surgical techniques or anatomical relationships. "This is all completely foreign to me," Tyler said honestly. "I don't understand how any of this works." Yet during his surgery, Tyler had demonstrated comprehensive understanding of every aspect of these procedures and anatomical relationships. Tyler's case raised disturbing questions about the nature of consciousness, medical knowledge, and what happens to human awareness during surgical procedures. If Tyler had somehow accessed information and understanding that existed outside his normal consciousness, it suggested possibilities that challenged fundamental assumptions about human cognition and awareness. I began researching theories about consciousness that might explain Tyler's experience. Some researchers had proposed that consciousness might not be entirely generated by individual brains, but might involve access to information fields that exist independently of physical neural structures. Other theories suggested that under certain circumstances, such as trauma or anesthesia, individuals might gain access to collective knowledge or universal information that is normally filtered out by normal brain function. But none of these theories could adequately explain Tyler's specific experiences or provide a framework for understanding how he had gained access to detailed medical knowledge and real-time hospital information during his surgery. Tyler's case also raised ethical questions that I was not equipped to answer. If patients could somehow maintain consciousness during surgery while appearing to be adequately anesthetized, what were the implications for surgical consent and patient autonomy? If Tyler's consciousness had truly been separated from his physical body during surgery, observing the procedure from an external perspective, what did that mean about patient privacy and the nature of medical intervention? Most disturbing was the question of whether other patients might be having similar experiences during surgery without anyone being aware of it. How many surgical procedures might involve conscious awareness that goes unrecognized because patients don't vocalize their experiences the way Tyler had? 3 months after Tyler's surgery, I made the decision to leave my position at St. Thomas West Hospital. I couldn't continue working in operating rooms while wondering whether patients were experiencing forms of consciousness that challenged everything we understood about anesthesia and surgical care. Tyler's case had fundamentally altered my understanding of what it meant to care for patients during surgery. If consciousness could exist independently of physical brain function, then every surgical procedure might involve aspects of patient experience that we were completely unaware of. I submitted my resignation and moved to a position in outpatient nursing, where I could provide patient care without the complex questions about consciousness and awareness that had made surgical nursing impossible for me to continue. Tyler has made a complete recovery from his injuries and returned to his construction work. When I contacted him several months after his surgery, he remained completely unaware of his extraordinary behavior during the procedure and continued to show no knowledge of medical or surgical principles. Miss Fletcher, I'm grateful for the excellent care I received, but I really don't remember anything unusual about my surgery, Tyler told me. It seems like it was just a normal operation to fix my injuries. The medical team that participated in Tyler's surgery has continued working at St. Thomas West, but each of us has been profoundly affected by the experience. Dr. Walsh has mentioned that she approaches every surgery with greater awareness of the possibility that patients might be experiencing consciousness in ways we don't recognize. Dr. Adams has begun researching alternative theories of consciousness and anesthesia, trying to understand whether Tyler's experience represents a rare phenomenon or something that occurs more frequently than we realize. Dr. Foster, our surgical resident, has reported that Tyler's case has made him more attentive to patient responses during procedures, looking for signs of awareness or consciousness that might normally be overlooked. The case of Tyler Bennett will always remain the most unexplained and disturbing experience of my nursing career. It taught me that consciousness might exist in forms and locations that medical science doesn't recognize, and that surgical procedures might involve patient experiences that we are completely unaware of. I continue to wonder whether Tyler's remarkable consciousness during surgery represented a unique phenomenon, or whether it revealed something that occurs regularly but goes unrecognized. If patients routinely experience forms of awareness during anesthesia that we don't detect, it would fundamentally change how we approach surgical care and patient consent. Most haunting is the possibility that Tyler's consciousness had truly separated from his physical body during surgery, allowing him to observe not just his own procedure, but hospital operations throughout the facility. If consciousness can exist independently of physical brain function, then everything we think we know about the nature of awareness, medical intervention, and what it means to be human may be based on incomplete understanding. I sleep better now in my outpatient nursing position, caring for patients who don't require the complex surgical interventions that defined my operating room career. But I still wonder about the dozens of surgical procedures that take place every day, and whether they involve forms of patient consciousness and awareness that remain completely unrecognized by medical teams. The impossible consciousness I witnessed that November day still haunts me, not because of what it meant for Tyler's specific case, but because of what it suggested about the nature of human awareness and the possibility that consciousness might transcend physical limitations in ways that medicine has yet to understand or acknowledge.